Hi, everyone. My name is Claire Elliot. I completed my practicum with Interior Health, working with the Strategic Initiatives Population Health team on a physician quality improvement project. Today, I'll be presenting this culminating project with you all, which examines health equity and access to prenatal care in rural interior health, with a specific focus on Merritt, British Columbia. My role involved conducting an equity-informed analysis of current service delivery, engaging partners across the system, and contributing to the development of early system-level improvement recommendations. Before I begin, I'd like to start my presentation off by recognizing and acknowledging the lands that my practicum organization and myself are situated in, which is the Silks Territory, colonially known as Kelowna. Interior Health also serves the traditional ancestral and unceded territories of the Tekel-Dene, Tunaha, Inca Clacma, Shwepum, Statliam, and Chilcotin nations. As an uninvited settler and a registered nurse and MPH student working within the healthcare system, I recognize my responsibility to approach this work with humility, engage in meaningful collaboration, and uphold and respect Indigenous leadership. So to understand why we chose this project, it's important to first consider the broader public health issue at hand. Prenatal care is a foundational public health intervention that supports early risk identification, continuity of care, and improved maternal and infant outcomes. However, access to prenatal care is not experienced equitably, particularly in rural and remote communities. Through literature review, data collection, and engagement, I identified several barriers, including travel distances, provider shortages, fragmented referral pathways, and experiences of systemic racism. Together, these factors contribute to delayed access to care, reduced continuity of care, decreased trust in the healthcare system, and increased risk of avoidable complications for both parents and infants, such as preterm birth, low birth weight, and neonatal mortality. While barriers to access are well documented, there's still limited clarity on what works in smaller rural communities like Merritt to address these challenges. Merritt was identified as a priority rural community within Interior Health, serving as a regional hub for surrounding rural and remote populations and uniquely located near 6 First Nations communities. While some primary care services are available locally, maternity care is limited, requiring many to travel to regional centers, most commonly Royal Inland Hospital in Kamloops. Inpatient referral patterns from 2020-2021 show that 28% of inpatients are served locally, while 53% are referred to Kamloops, approximately 87 kilometers away or a 1-hour drive under typical conditions. This reliance on regional care introduces significant access barriers, including transportation challenges, financial burden, and disruptions in continuity of care. In the past year, service disruptions at the nearby tertiary centers that they typically rely on, including Kelowna and Kamloops, have further intensified these challenges, creating an urgent need for more support. Available regional data also indicates higher infant mortality rates for the Thompson Caribou Shuswap region compared to other interior health regions. Finally, Merritt also experiences broader social health inequities, including in income, employment, chronic disease burden, and early childhood vulnerabilities. Altogether, this highlights both a significant gap and an opportunity to implement and scale equity-focused improvements. The purpose of this project was to really examine barriers to prenatal care access in Merritt, identify structural and system-level gaps, and inform feasible equity-oriented recommendations within the existing system. Longer term, this work aims to generate insights that can inform scalable, equity-focused improvements across rural interior health communities. In this project, I used a mixed methods equity-informed approach. I first conducted a literature review to help establish known barriers and evidence-informed approaches in rural settings, ensuring the work was grounded in both evidence and local context. A health equity impact assessment was then applied to support an environmental scan and examine how current prenatal care delivery differentially impacts populations. Both quantitative and qualitative data were integrated. Quantitative indicators included prenatal testing completion rates and service access locations, while qualitative data was collected through surveys and focus groups to capture lived experiences and system navigation challenges. Together, this approach enabled a more comprehensive understanding of system-level patterns, reinforcing that quantitative data alone does not fully capture how individuals experience care, and highlighting the benefits and the challenge of accessing disaggregated data in equity-focused work. These findings were then used to inform the development of targeted change ideas using a quality improvement approach. Several key findings emerged from this work. Firstly, access to prenatal care is shaped not only by service availability, but by how care is organized and delivered. In Merit, the limited local capacity results in heavy reliance on regional referral pathways, which shifts the burden of access onto the individual. As a result, transportation barriers and disruptions at the tertiary centers directly and disproportionately impact access to care. Secondly, referral pathways are often fragmented and unclear. Individuals frequently navigate multiple entry points without clear guidance, contributing to gaps across the prenatal journey and reduced continuity of care. Thirdly, gaps in culturally safe and relationship-based care negatively impacts trust, engagement, and care experiences, particularly for Indigenous families. Overall, these findings demonstrate that inequities are structural rather than solely geographic. These challenges are not experienced equitably. Indigenous families, rural residents, and individuals without consistent primary care providers are disproportionately impacted. Health equity recognizes that different populations face different barriers to care, and that equitable outcomes require supports based on need rather than treating everyone the same. In this project, structural factors, including income, health literacy, access to transportation, and access to culturally safe care, were found to intersect and compound barriers to prenatal care access, resulting in delayed or missed appointments. This reinforces that addressing inequities requires attention to underlying social and structural determinants of health, not only service availability. Based on these findings, I contributed to the development of 3 key improvement strategies. The first recommendation focused on improving navigation through a centralized referral pathway to support earlier and more direct connection to care. One of the consistent challenges identified was that individuals often don't know where to go or how to access care early in pregnancy. In response, we developed a simplified flow pathway and referral form that enables the central intake line to directly connect clients with prenatal care providers rather than only providing general information. The second strategy emphasized advancing partnerships with Indigenous communities to support culturally safe, community-informed care. This recognizes that improving access is not only about service availability, but also how care is experienced. Engagement with Indigenous organizations and health directors identified strong interest in partnership and opportunities to co-develop approaches grounded in Indigenous knowledge and leadership. The third strategy explored a mixed models of care to increase system capacity, continuity, and access closer to home. One proposed model, developed in partnership with the Shwekam-Kokahela Primary Care Clinic, brought together multiple providers to work within one care setting. This included a nurse practitioner, public health nurses, allied health providers, and importantly, Indigenous care providers like an Indigenous midwife or doula. Together, these strategies reflect a shift from focusing solely on service availability to addressing how care is coordinated, accessed, and experienced within the care system. This work highlights several key implications for public health practice. First, inequities in prenatal care are shaped by system design, not just geography. Second, improving access in rural settings requires coordination, integrated models of care, and strengthened navigation pathways. Third, advancing health equity requires culturally safe and community-informed approaches, particularly for Indigenous populations. Finally, this work underscores the importance of cross-program collaboration in achieving effective and sustainable system-level change. One of the most valuable aspects from this work was bringing together partners from across programs, which helped build a shared understanding and reduce siloed approaches to prenatal care access. I'd like to extend my sincere thanks to my practicum supervisors, Dr. Fatima Sabet and Julian Mallison, for their guidance and support throughout this project. I'm also deeply grateful to Fatima and our project co-lead, Karen Cooper, for championing this work and their commitment to health equity, as well as to Daniel, our health equity lead, for his insight and wisdom. From the university, I'd like to thank Mira for her ongoing guidance and support, and I'd also like to thank my workplace colleagues, as well as my friends and family, for their encouragement throughout this entire journey. This practicum was an incredible experience, and I'm hopeful and excited to continue to develop and apply my new knowledge and skills to future work. Thank you for your time today.